Okay, let's be totally honest here. Is your brain just completely fried right now? Like, are you practically vibrating from your fourth iced coffee, staring at a mountain of textbook pages and desperately trying to figure out what is actually going to be on the clinical judgment exam? I see you, caffeinated nursing students. You're exhausted, and you need a no bullshit rapid fire review to lock in the core concepts. Well, that is exactly what we're doing today. Take a breath, put down the highlighter, and let's get you ready to absolutely crush this exam.
Welcome to this explainer. You can kind of think of this as your virtual shift, like the ultimate cheat code for exam day. We're skipping the fluff and the filler to bring you exactly what you need to know. The CJE isn't just about memorizing random facts. It's about making safe, priority decisions when everything is hitting the fan. So, we're going to build that clinical reasoning right here, piece by piece. So here's our game plan for this shift. We're covering fluids and elimination basics, functional ability and falls, ethics and family dynamics, glucose regulation in emergencies, and finally, some high-yield CJSE reminders. All right, let's just get to work. Okay, let's dive into this. Section 1, Fluids and Elimination Basics, the messy realities that dictate patient stability. Seriously, if you don't know your patient's intake and output, you don't really know your patient at all. A massive part of clinical judgment is just recognizing when a patient is either drying up or basically drowning in their own fluids. Think about dehydration. The tank is empty, so the heart is pumping faster to compensate. Hello, tachycardia. But the pressure drops, so you get hypotension. Plus, you'll see dry mucous membranes and really concentrated urine. On the flip side, fluid overload means the tank is overflowing. That's where you're going to see edema, crackles in the lungs, JVD or jugular vein distension, sudden weight gain, and shortness of breath. You absolutely cannot mix these up on test day. If your patient has crackles and bounding pulses, please do not give them more IV fluids. Now let's talk electrolytes. The real trick here is mapping the specific imbalance to its primary danger zone. When you see sodium issues, like hyponatremia, I want you to immediately think neuro. We're talking confusion, we're talking seizures. Hypernatremia, that's your classic dehydration buddy. But potassium? Man, potassium pays the bills for the heart. Hypokalemia causes weakness and dysrhythmias, and hyperkalemia? Your alarm bell should be screaming for fatal cardiac dysrhythmias. If potassium is off, the heart stops, period. Let's rapidly break down some elimination red flags. Who's actually at risk for urinary retention? Well, look for your post-op patients on anesthesia, anyone on opioids, or folks with an enlarged prostate. If they've got bladder distension or they're just, dripping frequent little amounts of urine, they are retaining. For bowels, remember that opioids and immobility are prime culprits for constipation. But if they have diarrhea, your priority isn't just to stop the poop, it's watching out for dehydration and electrolyte loss. Oh, and if the exam asks about an ostomy stoma, pink, red, and moist is literally the only acceptable answer. If it's pale, dusky, or black, that tissue is dying, and you need to call the provider immediately. Moving on to catheter care. This is a brilliant illustration of basic infection prevention, which the CGA absolutely loves to test. First, keep the bag below the bladder so urine doesn't backflow. Second, avoid dependent loops in the tubing where urine can just sit and pool. Third, strict sterile insertion is a must. And fourth, advocate to get that catheter out ASAP. Seriously, every single day it stays in is another day the patient is at risk for an infection. Speaking of infections, lock this concept into your brain right now. It's a classic CJ trap. A younger adult with a UTI comes in complaining of a fever, burning when they pee, urgency, the usual stuff. But an older adult, they might not spike a fever at all. Instead, they might show up with sudden confusion, unexpected falls, weakness, or just really bizarre behavior changes. So if grandma suddenly doesn't know what year it is, check her urine. Right, moving on to section 2, functional ability and falls. Keeping the patient safe and moving. Just picture walking into your patient's room. What are the immediate hazards and what can your patient actually do for themselves? First off, know your ADLs, activities of daily living. Bathing, dressing, toileting, eating, transferring. If they can't do these, they're a huge fall risk. Who else is a risk? Older adults dealing with dizziness, confusion, weakness, or anyone who's heavily medicated on sedatives. Your interventions here are simple but incredibly vital. Get those non-skid socks on them, keep the bed in the lowest possible position, make sure the call light is actually within reach, and use assistive devices. And look at how this builds. If a patient falls, or even if they just stay stuck in bed, you're looking at severe immobility complications. Things like pneumonia because they aren't expanding their lungs, constipation, nasty pressure injuries, and deadly DVTs. You've got to keep them moving. All right, Section 3, Ethics and Family Dynamics, navigating the human element of nursing. Because let's face it, the exam isn't just going to test your clinical skills, it's heavily testing your legal and ethical boundaries.
These 5 ethical terms, they are guaranteed easy points on the exam if you just memorize them right now. Autonomy is the patient's absolute right to choose or refuse treatment, even if you personally think it's a terrible idea. Beneficence simply means to do good. Non-maleficence is all about doing no harm. Justice means fairness and care. And veracity, that just means telling the truth. Oh, and never, ever forget your duty to protect patient confidentiality and HIPAA. Absolutely no elevator gossip, folks.
Now, this single concept will save your life on the exam. The nurse's role in informed consent is to witness the signature and verify the patient's understanding. That's it. You are not the surgeon. You are not the one explaining surgical risks, alternatives, or specific complications. If the patient is holding the pen and says, "Wait, what exactly are they cutting out of me again?" you stop right there and call the provider back into the room. Next up is the family. You have to remember you aren't just treating the patient in the bed. You are assessing the caregivers for stress, exhaustion, depression, and burnout. When you talk to them, rely heavily on therapeutic communication. Use open-ended questions, reflection, empathy, and sometimes just comfortable silence. But what should you avoid at all costs? False reassurance. Do not ever tell a family everything is going to be fine. You don't know that for sure. It's total BS, and the CJE will definitely dock you for it. Instead, take actual action. Provide support resources, education, and arrange for respite care so that poor caregiver can finally take a breath. Okay, deep breath, because we're entering code red territory. Let's clearly separate the highs from the lows here. Hypoglycemia, low blood sugar, is cold and clammy, sweating, shakiness, confusion, and tachycardia. They need sugar and they need it fast. Hyperglycemia, high blood sugar, is warm and dry, severe thirst, polyuria, which is peeing constantly, and blurry vision. But if that high blood sugar progresses to DKA, diabetic ketoacidosis, that's when you see the classic fruity-smelling breath, those deep and rapid Kussmaul respirations, severe dehydration, and positive ketones. Now, what's really interesting here is how the patient's level of consciousness completely changes your nursing intervention. If a patient is hypoglycemic and conscious, meaning they can safely swallow, you treat them right away with 15 grams of fast-acting carbs, think juice or glucose tabs. But if they're unconscious, please do not pour juice down an unconscious person's throat. That is an aspiration nightmare. An unconscious patient requires intramuscular glucagon or IV dextrose. So remember, the level of consciousness dictates your route. And while we're talking about blood sugar, treat these 2 rules as the golden, non-negotiable laws of pharmacology for your exam. Rule 1, only regular insulin can be given through an IV. Rule 2, when mixing insulin in a single syringe, you always drop the clear, fast-acting insulin before the cloudy, long-acting insulin. Clear before cloudy, every single time. Almost there. Section 5, high-yield CJ reminders, the cheat codes for exam day. Think of this as a rapid-fire association exercise for those tricky concepts instructors absolutely love to sneak into case studies. You need to drill these cause and effect pairings into your head. If a patient is severely vomiting, they're throwing up stomach acid, right? Losing acid means they swing into metabolic alkalosis, and they lose potassium, which leads to hypokalemia. If they have severe diarrhea, they're losing base from the lower GI tract, which plunges them straight into metabolic acidosis alongside dehydration. And if they have COPD, they are trapping CO2. CO2 is an acid, which leads directly to respiratory acidosis. If you see the condition, you should instantly know the imbalance. I know I mentioned this earlier, but I am saying it again because it is just that important. Sudden older adult confusion is a massive red flag. On a nursing exam, it is never, ever just old age or dementia getting worse. It is a physiological cue demanding your investigation. 9 times out of 10, it points to an underlying infection like a UTI, hypoxia, severe dehydration, or hypoglycemia. You have to investigate the cause before you brush it off. When you're staring blankly at a multiple-choice question where all 4 answers look totally 100% correct, you have to fall back on the holy grail of nursing priorities, the ABCs: airway, breathing, circulation. Securing a clear airway and ensuring the patient is actually breathing will always be your ultimate priority. It comes way before taking a blood pressure or starting an IV. Live and die by the ABCs. Let's wrap up this shift with one final thought to chew on.
Why is hypoglycemia considered a rapid emergency over almost all other imbalances? Hint: think about what your brain relies on exclusively and what happens when it has absolutely zero ability to store it. Knowing the why behind that physiological crash, that's how you move from just memorizing flashcards to actually mastering clinical judgment. You've got the tools, you've got the cheat codes, get some sleep, trust your gut, and go absolutely crush that exam.